I'll now invite Dr. Deepak Megur to speak on pseudoexfoliation and small pupil.
Is it on? People are coexisting, but we need to understand that, apart from just the pupil, the zonular compromise, health of the zonular compromise would be significant in these patients. So, apart from the pupil, we are also concerned of the zonular health when dealing with pseudoexfoliation. To deal with the pupil, as has been discussed, we have got many options, iris hooks, which were the initial choices for all of us. Then we based on ring-based devices. And this is an 80-year-old man who has got pseudoexfoliation, loose zonules, rigid pupil. So one way to go around in this very thin thing is you want to pre-stretch the pupil so that you get better mydriasis when you are using a BX device. Because as it is very thin and flimsy, its ability to stretch the pupil on its own might be difficult. But another advantage of using any device after you stretch is once you stretch, the iris can become floppy. So to prevent that, to hold it in place, these devices work very well. So if you are dealing with a rigid pupil, you have to pre-stretch a little bit before using these the BX ring so that you get better mydriasis. And it is not, there is a short learning curve for it. And the one trick I would like to say is, always stabilize the globe with your second hand. So because eye does not move away from primary position, you see well when you're trying to engage them. So most of the beginners, when they try to do it, the eye would be rotating and they would not be figuring out where the pupillary margin is, and they'll be struggling for it. Especially when the visualization is challenging because of thick carcass or cornea, which is not great. So always in the moment we touch the capsule, that is the time in which we really know the health of the zonules. Until then, we really can't know. So be very attentive in eyes with pseudoexfoliation. And hydrodissection is probably the most important step, which will tell you that how good or bad the zonular health is. So I would prefer to insert a CTR before. As you saw, I was first creating some space by injecting OVD inside. And with the nucleus inside, the CTR could be managed. What it gives an advantage is that it provides us 360-degree equatorial support as you're maneuvering with these denser nucleus. So in such situations, if the zonules are a little bit iffy, I wouldn't hesitate to go ahead and insert the CTR a little bit earlier than what conventionally has been taught to us. So again, your nucleus division process all are going to be standard, and then you're going to place the lens as you have been planned. And as it has been always discussed, one of the greatest advantage of this device is the thin profile, and because of that, the removal is quite easy. So other things are biplanar you can also remove them with forceps, but there's always a thing that it gets snagged at the pupillar margin or the wound itself. So there is a way around it, you just press it down and pull it out, but that's it. And the pupil never gets distorted, or you have a cosmetically better looking pupil. Now at this point, I'd like to just show you, this was a classical case, and there are some difficult situations which you get into and you have a ring inside. Now how do you deal with such situations? I'd just like to take you through. So this is a pseudoexfoliation case, and once the nucleus is come out, suddenly the eye becomes hard now. Now this is because there is a fluid misdirection, there is a compromised zonules, and I can't proceed with a cortex extraction at all. You can see the tiny lens particles behind it, suggesting of the fluid which has gone behind, and the eye is tense because the fluid is in the burger space, and there's total lack of space for me to proceed further. So I'm struggling to introduce my cannulas inside, and it is a situation where I'm more likely to break the posterior capsule at this stage. So at this stage, surgery temporarily suspended. I start mannitol, wait for about 15 to 20 minutes after about half of the mannitol is over, and then you can see that the eye softens a little bit, and the BX ring is still on. I've not done anything. I'm just waiting in the OR. And using cohesive OVD, you can deepen the chamber, and then inserting the CTR, the lens goes in place. And then you are going to remove this thing. And whenever you have this iris prolapse, avoid pushing it many times inside. Okay, just if it comes out, just leave it there. Work under very low pressure. Retract the iris, try to align it in the desired axis. This is a toric lens, and you'll be surprised that the iris still retains its cosmetic appearance. The another case of similar fluid misdirection, where the patient just moves the eye. I have a small PC tear, and this has still escaped my attention, and you can see the PSU capsule blows out, and the second ring appears now. The second ring is the anterohalide rupture. So there was an interval between the first posterior capsular tear and the anterolateral rupture. It took some time, and if you're not alert, this was because I wasn't too attentive. I could have prevented the anterolateral rupture, but it wasn't to be. So naturally the vitreous prolapse is there. You're going to deal with the vitreous prolapse. I'm just showing, like, if you end up having a complicated situation with the BX ring also, it is actually an advantage. Imagine if this complication has happened and your pupil has come down, then you're in a lot of problem. So do vitrectomy. I'm just trimming the posterior capsule tear so that the visual axis is just cleared off. And now I need to place the lens in the sulcus. I'm placing a multi-piece lens, creating space under the iris using a sodium hyaluronate. Enlarging the incision is a great tip here, because the eye would be soft after vitrectomy. And then you guide the distal haptic under the iris and above the capsule and gently dial the lens inside. So even with the ring on, in a compromised situation also, you can do and position the lens where you want, because the visibility is great and is not compromised. And many times there's a question always asked that if the BX ring is there, will it, the haptic just get stuck in such complicated situations where the space is less? It doesn't really so, you just create some space with OVD and you can manage it well. And here in this situation, I'm achieving optic capture under the irrigation itself, and usually I prefer to remove the BX ring under OVD itself. But in this case, the OVD is already out, the irrigation is still on, and in this situation I'm just disengaging and trying to remove it under hydro unit itself. There is a small risk here, because sometimes you may end up causing a descemet detachment and all those things using under irrigation itself. So my preference is always going to be used under OVD, but in such situations you can do it. And okay, BX ring for most routine cases fine, but iris hooks do have a role in play in my practice as well. So whenever situations where we want a larger pupil, for example, rhexis has gone to the periphery, or we have a peripheral posterior capsular tear where you're not able to visualize it well, or you want to convert from phaco to SICS. Now this is a patient where the pupil is extremely rigid and the rhexis has gone radial. This is a one-eyed patient. I wouldn't want to risk anything. The BX ring comes out, and you're going and putting it your 5 rings, and then you're able to see well where the rhexis margin is, and you can position your lens appropriately, and ultimately the visual outcome would be better. Similar situation would be, you have a situation of a peripheral posterior capsular tear. The BX device cannot give us a visualization in that particular quadrant. So the best situation in this would always not to hesitate to use iris hooks. It gives the necessary visualization. Where is the tear? Where is the rhexis margin? You do a nice vitrectomy, and then under direct visualization, you can always go in and place the haptic over the rhexis margin, even these complex situations also. So the moral of the story is you need to be well versed with using as many tools as you can, and depending on those situations, choose them wisely. Thank you for attention.
Thank you very much, Dr. Deepak. We have just finished on time, but though we got the hall a little late, if there is a quick question, we could answer that, or we could take the questions after the session.